watch for. Oxygen toxicity, presenting as a non-productive cough, substernal chest pain, nasal stuffiness, nausea, vomiting, fatigue, headache, sore throat, and hypoventilation. You'll monitor for dry nasal passages, suppressed respiratory drive, and skin irritation and breakdown from the delivery device. Oxygen is very drying to the mucous membranes and should be humidified. Frequent mouth care is also essential for clients receiving oxygen therapy. And now, a nurse from the State Health Department's Communicable Disease Division is about to give a presentation on tuberculosis. Let's watch it now.
Let's review what you've learned about tuberculosis. It's a contagious disease that is becoming resistant to current therapy. It can affect any organ, but it primarily affects the lungs. The initial infection develops within 2 weeks of exposure, but it may remain dormant for years. It's a major public health problem worldwide, and it's transmitted through airborne droplets. The risk factors for tuberculosis include direct exposure, compromised immune status, crowded living conditions, and being an injection drug abuser. Other risk factors include alcohol abuse, malnourishment, low socioeconomic levels, advanced age, chronic illness, and institutionalization in shelters, prisons, and long-term care facilities. Do you remember the signs and symptoms of tuberculosis? It can be asymptomatic early in the disease, but clients eventually develop a non-productive cough progressing to purulent sputum and hemoptysis, low-grade fever, night sweats, pleuritic chest pain, weight loss, anorexia, fatigue, and malaise. The diagnosis is made through a history and physical, then a skin test is performed. If the test is positive, the skin test might be repeated or a chest x-ray ordered. If the chest x-ray looks questionable, then sputum smears and cultures will be done. The most effective management tool for tuberculosis is prevention of transmission to others. Teach your clients how to prevent transmission through mouth care, covering the mouth when coughing or sneezing, proper disposal of tissues, and thorough hand washing. A client who must be transported from one room to another room or department must wear a mask to prevent transmission. Nursing management also includes monitoring your client's respiratory, nutritional, and fluid status, as well as the effectiveness of drug therapy and compliance with the drug therapy regimen. Implement respiratory isolation if indicated, as well as directly observe therapy if doubts about compliance arise. Pharmacotherapy for tuberculosis includes antibacterials such as isoniazid and rifampin. These are the two most commonly given and should be taken on an empty stomach. Others include ethambutol, pyrazinamide, and streptomycin. Vitamin B6 is given to prevent toxicity from isoniazid. The complications of tuberculosis are extrapulmonary tuberculosis and death.
So, do you feel pretty comfortable about your knowledge of TB? If so, we'll move on to pulmonary embolism. Pulmonary embolism is a life-threatening complication that can result from thrombophlebitis, surgery, or immobility. Most emboli originate as thrombi in the deep veins of the lower extremities. The thrombus detaches, travels to the right side of the heart, is circulated, and lodges in one or more branches of the pulmonary artery, where it causes partial or complete occlusion. Death can result immediately or within 2 hours following a massive pulmonary embolus. When pulmonary embolism is suspected, you will assess the client for dyspnea, tachypnea, sudden onset of chest pain, tachycardia, anxiety, cough, hemoptysis, and diaphoresis. How would you position this client? On the left side, with the head lower than the heart if the client can tolerate it, and administer supplemental oxygen immediately. Clients at greatest risk for pulmonary embolism are those who have deep vein thrombus, have just had orthopedic, pelvic, gynecologic, or abdominal surgery, have hypercoagulability disorders associated with anemia, are taking estrogen therapy or birth control pills, smoke, experience prolonged immobility, are pregnant, are obese, have congestive heart failure, or are of advanced age. So it is important when we are caring for these clients that we institute measures to prevent pulmonary embolism. For example, when you have a postoperative client who is immobilized, encourage leg exercises or provide passive range of motion exercises. Be sure to watch these clients carefully for signs and symptoms of pulmonary embolism. Monitor their vital signs, assess respiratory status, and be alert for any indications of compromise. Watch for signs of hypoxia and bleeding, and monitor prothrombin time, or PT, International Normalized Ratio, or INR, and partial prothrombin time, or PTT levels. Many clinicians use Homan sign, calf pain elicited while dorsiflexing the foot with the knee flexed, to check for thrombophlebitis. It has been shown, however, that this sign is nonspecific and not consistently accurate. Still, a positive finding would warrant further investigation, especially in a client at risk for pulmonary embolism. A variety of diagnostic measures are used to confirm pulmonary embolism. These include chest X-ray, ABGs, pulmonary angiography, ECG, ventilation perfusion scan, PT, and PTT, and impedance plethysmography. How will you care for a client at risk for pulmonary embolism? Explain the diagnostic procedures and prepare him as needed. Keep him on bed rest in semi-Fowler's position. Administer warfarin or Coumadin or one of the newer low molecular weight heparins, such as enoxaparin or Lovenox, as prescribed. The client might also have thrombolytic therapy and will receive pain medication to promote comfort and relieve anxiety. You'll monitor the client not only for the effectiveness of the therapy prescribed, but also for potential complications, such as bleeding as a result of anticoagulant therapy. Clients on anticoagulant therapy need extensive teaching. If heparin is prescribed, it will be administered IV or subcutaneously. Heparin inhibits the conversion of fibrinogen to fibrin,